Something strange in your neighborhood. Who you gonna call? Ghostbusters! If there's something weird and it don't look good, who you gonna call? Ghostbusters! I ain't afraid of no ghosts. I ain't afraid of no ghosts. If you're seeing things running through your head, who can you call? Ghostbusters! An invisible man sleeping in your bed. Oh, who you gonna call? Ghostbusters! I ain't afraid of no ghosts. I ain't afraid of no ghosts. Who you gonna call? Ghostbusters! If you're all alone, pick up the phone and call Ghostbusters! I ain't afraid of no ghosts. My head likes the girls. I ain't afraid of no ghosts. Yeah, 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 yeah. Who you gonna call? Ghostbusters! If you had a dose of a freaky ghost, baby, you better call Ghostbusters! Let me tell you something. Bustin' makes me feel good. I ain't afraid of no ghosts. I ain't afraid of no ghosts. Don't get caught alone, oh no. Ghostbusters! When it comes through your door, unless you just want some more, I think you better call Ghostbusters.
Good morning, everyone. Welcome to our webinar, part of the Diabetes and Special Populations National Learning Series. My name is Cindy Selmy, and I am from Health Outreach Partners. Today, we will have a very lively webinar discussing diabetes continuum of care, developing patient-centered resources for diabetes care. We are happy to be here. I want to take a minute to introduce our faculty, our moderators, and our organizers. First, I would like to acknowledge Albert Eisen Jr. from APJO. He has been instrumental in planning and facilitating and leading our efforts on our National Learning Series. I am from Health Outreach Partners and have been learning a lot from Albert this year. I also want to welcome Emily Kane, Senior Program Manager from the National Nurse-Led Care Consortium. Her colleague, Jillian Bird, Nurse Training Manager, also from the National Nurse-Led Consortium. Darlene Jenkins, Senior Director of Programs from the National Healthcare for the Homeless Council. And last but not least, Alexis Guild, Director of Health Policy and Programs from Farm Worker Justice. So welcome, everyone. Just a few notes about Zoom, some Zoom housekeeping. Everyone will remain muted for the entire webinar. If you would like to ask a question, we ask that you use the Q&A box that you will see at the bottom of your screen. And if you want to communicate with any of us on the panel or the presenters, please note we will be monitoring the chat as well. So thank you very much. Next slide. Just a few notes about our series. Diabetes affects more than 31 people in the United States, and it has been recognized that we need to have a multi-tiered effort to treat and control diabetes, particularly in vulnerable populations. According to HRSA's UDS data, 1 in 7 patients who come to our health centers has diabetes, while 1 in 3 of those patients has uncontrolled diabetes, creating very unique challenges for our health center program. We, the Special and Vulnerable Populations Task Force, part of the National and Training Technical Assistance Partner organizations, there are 14 of our organizations that serve on this task force. We have set out to elevate the conversation, engage health centers, primary care associations, as well as health center control networks to increase the knowledge and effective strategies around diabetes and diabetes care. Our learning series this fall is sponsored by HRSA, and we encourage you and invite you to check out our website, chcdiabetes.org. Next slide. The 14 members of the Special and Vulnerable Populations Task Force you shall see here. We thank all of our partners, APJO, Health Outreach Partners, Farm Worker Justice, Migrant Clinicians Network, MHP Salud, the National Center for Equitable Care for the Elderly, the Corporation for Sustainable Housing, the National Healthcare for the Homeless Council, the National Center for Health and Public Housing, the National Network for Oral Health Access, the National Nurse Care Consortium, School-Based Health Alliance, and Fenway. Next slide. Today is webinar number 2 in our series, and we also want to encourage you to register for webinar 3 next Wednesday, November 3rd, Diabetes Continuum of Care, Improving Diabetes Care and Health Equity in a Changing Healthcare Landscape. And we are very excited to announce webinar number 4 on November 10th, which will be our first webinar in Spanish, addressing diabetes management during a disaster. So please join us for that. Continuing education credits and nursing credits are available during this webinar. To receive your education credits, you must complete the post-activity evaluation. The link and the QR code will be available at the end of this webinar. Once it has been verified, each participant will receive an electronic copy of their certificate. If you have any questions, we thank our partners at Migrant Clinicians Network for providing these units. Please email Jillian Hopewell at migrantclinicians.org. All of the members of our panel and our moderators and our partners have no real or perceived vested interest that relates to this presentation, nor do we have any relationships with pharmaceutical companies, biomedical device manufacturers, or other corporations whose products or services are related to pertinent therapeutic areas. I just want to take a moment to acknowledge the effects of COVID-19 and on people with diabetes. Health centers have played a vital role in the national response to the COVID-19 virus. and COVID-19 resources for health centers by all 21 national training and technical assistance partners and partnering organizations are available on the Health Center Resource Clearinghouse. Please visit the clearinghouse for more information. People with diabetes are not more likely to get COVID-19 than the general population. While it has been noted that people with underlying chronic medical conditions like heart, lung disease, and diabetes seem to be at higher risk for developing more serious symptoms and complications when infected with the COVID-19 virus. If one's diabetes is well managed, the risk of getting severely sick from COVID-19 is about the same as the general population. We encourage folks to stay healthy during this global pandemic and to please visit the CDC's website for more information, as well as the other resources listed on our slide. I will now turn it over to our panel and our presenters to review the learning objectives.
Hi, everyone. Good morning. Good afternoon. My name is Emily Kane, as Cindy said, and I'll just be going over our learning objectives today and then also introducing our interactive tool that we're going to be using today. So during our presentation, we want to understand the role of cultural humility in the development of patient-centered resources, incorporate strategies that involve the patient population in the development of resources to ensure that they reflect their needs, and then finally share examples of patient-centered interventions for health centers serving diverse patient populations. So we're going to accomplish all that today with 3 amazing speakers and hopefully a lot of conversation and discussion among all of you. So to accomplish that today, we're going to use Mentimeter. It's an interactive tool that allows you to participate in polls and word clouds and chats so that we can all join in the conversation together. So the easiest way to use this is to have a cell phone that you can pull up the browser, or you can just open another browser alongside this webinar. Go to menti.com, and there will be a code at the top of the next slide that you can enter in, and that will be your code to join the polls. So I'm going to go ahead and make sure that that code is in the chat. But as you go to menti.com and then enter the code at the top of the screen, which is 97639129, I'd love for you all just to drop a pin into where you're joining from today. And I apologize if anyone is joining from Europe or somewhere that's not on this map, but assuming that most folks are coming from the United States. So wonderful. We're seeing already a great diversity of geographies and places where folks are coming from today. So again, make sure you're going to menti.com either on a phone or a browser, enter that code, and you can drop a pin where you're coming from. Wonderful. It's great to see. Okay, so we're going to just move on to the next slide in the interest of time. I'll give it maybe 5 or 10 more seconds just to see the pins keep popping up. Wonderful. Thanks, everyone. Next, we have a little bit of an icebreaker. You heard when you entered the webinar today, some Ghostbusters Halloween music. So just want to get a sense of what your favorite Halloween candy is. I apologize that not every type of candy is on this slide. We just sort of picked from among the many varieties. If you have very strong opinions about a candy that is not on this slide, you can certainly share that in the chat. Looks like Snickers is winning the day, which I'm a little sad for Hershey's down there with 0, but so we'll give that a few more minutes. It's good to think about something sweet. For me, I'm hitting the afternoon slump, so it's good to think about a Snickers. All right. So now that you all know how to use Mentimeter, we'll be able to use that as we do some activities during our presentation today. So thank you all for participating in those 2 slides. Really appreciate that. So with that, I'm going to turn it over to Darlene Jenkins, who's going to be talking about developing patient-centered resources for diabetes care.
Great. Thank you so much, Emily, and good morning, good afternoon to everyone, and welcome. I'm going to talk a little bit about implicit bias. So let's have the next slide, please, Emily. Thank you. So as you see our character here, we're going to have you use Mentimeter again for this exercise. How would you characterize this person? If you were to see this person coming to your health center, what first thing comes to mind when you see this character? What do you think? Okay. Okay. Happy, attitude, mad, moody. Yeah. Okay. Great. Okay. Older, skeptical. Yes. Many times annoyed. Very good. Okay. Next question. Next slide. What behaviors would you expect this person to exhibit? So thinking about the behaviors, and you can put this into, is this a chat? Emily, I think it's a chat, right?
Yeah, it's an open-ended.
Yeah, open-ended.
So feel free to
Okay.
put as many words
So-
as you want.
Yeah. Closed-minded, short-tempered, rude, unhappy. Okay, great. Ignore. And then finally, this is also kind of put as many words in the chat as you want in there as you want. How would you react if you met this person for the first time? How would you react if you met this person for the first time? Just thinking about. With a big old smile, ignore, intimidated, hesitant, okay, careful, sympathetic, on edge, defensive, kind, smile. Wonderful. Well, thank you. Thank you for participating in that. What we just participated in is just an exercise in implicit bias. And implicit bias, when we first see someone, we automatically size them up. I guess it didn't help that we picked someone as a character, Mr. Grumpy. So that kind of told you a little name, but even without knowing his name, as we look at an individual, we many times size them up. We can size them up based on what they have on, what side of town they may be coming from, looking at their address, and what our first thoughts are if what we describe as having implicit or unconscious bias. Think of it this way. It's in our thoughts. We really don't recognize it. Many thoughts are brought about by life experiences, the media, news programming, family impressions. They all contribute to the feelings and the attitudes that we have about other people. These feelings can be based on characteristics such as race, ethnicity, age, size, again, where we live, gender, or appearance. For example, if a person may be obese or if they're thin, or even accents. If a person has a Southern accent, we may have a bias, an implicit bias. We may draw conclusions about this person even by hearing their accent of how they're talking. So implicit bias, again, unconscious bias, is something that we're unaware of, and it's different than explicit bias, where we're fully aware of it and we actually admit to these deliberate thoughts. The Perception Institute explains it this way: thoughts and feelings are implicit if we are unaware of them or mistaken about their nature. So we have a bias or for person. So a bias can be both favorable as well as unfavorable. So we can have a preference for a thing, a person, or a group, or we can have an aversion to a person, a people, or a group. So you can have favorable bias, or you can have an unfavorable bias. For example, I know when I was in graduate school, we had a professor who actually admitted that he had an implicit bias. He said that found himself when he was grading tests, he was looking at and in graduate school at this time, they had us write our names on the back of the test paper. And so he said he was grading papers and he was reading through the responses on this test, and he was saying, well, wait a minute, I don't know what they're saying. Well, who is this? And so he turned the paper over and he saw the name of the student, and he said, oh, I know they come to class all the time. They listen, their homework's good. So I know they know what they're talking about. So he actually gave them a higher score than if he did not know who that person was. And so admitting that he actually had this kind of implicit bias, he asked us then to, instead of putting our names on tests, to actually put a number, or we were assigned student numbers. And so that's how he graded. He didn't know then who was submitting these answers. So he was not having any type of bias when he was grading. Again, bias can be unfavorable as well as favorable. Also, they have found that in many symphonies and orchestras, when people were actually auditioning for the symphony and orchestras, that there were less minority as well as less, I should say, minority or people of color, as well as women. And so they started doing blind auditions and found that the number of people of color as well as women who were accepted into the orchestra and the symphony increased. And so we have found that implicit bias does have an impact on how we provide care. And these are just some of the, on this slide, just some of the thoughts that someone may have when you encounter someone for the first time. Next slide, please. So implicit bias does impact patient-centered care. And this is what we're talking about, is really developing patient-centered resources. But we first have to understand that our implicit bias does impact how we provide care, as well as the resources that we give someone or the information that we give someone. So research has shown that implicit bias can impact care. Like a study was focused on racial disparities in diabetes care. And they found that healthcare providers with implicit bias regarding race, it directly corresponded with worse medical outcomes. And so many times with implicit bias, when you encounter people of color or a person who may be experiencing homelessness, they may not give them the information that they may need because they don't see them as following through or understanding. Research has found, and as you can see on our slide, that implicit bias has shown that non-white patients receive fewer cardiovascular interventions and fewer renal transplants. We find that non-white patients are less likely to be prescribed pain medications for non-narcotic or narcotic versus narcotic. Black men are less likely to receive chemotherapy and radiation treatment for prostate cancer and are more likely to have their testicles removed. We also have found during research that physicians with a high score of implicit bias tended to dominate conversations with Black patients. That means that they were trying to tell them more information, and that Black patients actually felt this implicit bias, and they had less confidence and trust in the provider, and they rated the quality of care, even though the provider was giving them more information and dominating the conversation. They did not feel that they were getting the care, and they did not trust the provider that was actually getting the abundant amount of information. They also, with research, has found that this is a research that was done with cancer patients, that providers with a high implicit bias had less support and were less supportive and spent less time with their patients than those with lower implicit bias. And so again, implicit bias can impact patient care, both the delivery and the information that is provided. And then finally, providers with high scores of implicit bias use language, and I thought this was very interesting. They use language such as we, ours, and us more frequently, such as, now we're going to take our medication more regularly, aren't we? So it was more of a telling of that rather than asking the patient to share their feeling. So those are some of the things that implicit bias, how it impacts patient-centered care. Next slide, please. So this is a direct quote from a patient that shared with us when we revised our adapted clinical guidelines for diabetes, and we asked people experiencing homelessness with diabetes what their first experience was when they went to the health center and they were diagnosed with diabetes. What type of feedback, what type of care, what type of information did they receive? And this is his direct quote. He said, "I went to the clinic, but they didn't tell me anything. They just gave me an insulin pen and left. I didn't even know how to use it. The next day I went back to the clinic and the medical assistants, that's the MA, showed me how to use it. I never received an education call. At this particular health center, they would do educational call for patients with diagnosed with diabetes, and this patient did not receive an education call. So I wish I would have been given instructions at the beginning. Some providers think that because I'm homeless, I don't have the mindset to learn. But if they would take the time to actually explain things, I can learn anything." So again, as we talk about how implicit bias impacts patient-centered care and the amount of information that we give patients, it does have a negative impact on that. Next slide, please. So let's talk about how we can actually mediate some of the implicit bias. And we can move to a relationship-based care, which helps mediate implicit bias. And when we're talking about relationship-based care, it's an intentional way of developing relationships with a patient or a client. So we don't have, even though we may have our first thoughts about this person, we actually take the time to learn who this person is, and we develop a relationship with them. So even when Mr. Grumpy comes in and we may be apprehensive, his name may be Grumpy, so we have these biases. Well, he doesn't want to listen. He's probably going to have an attitude. He's probably going to be very difficult. He's not going to comply to what I'm going to tell him. So why even bother? We put all that aside and we actually take the time to develop a relationship. And there's two ways that we can develop a relationship. It's by number one, on the organizational level. That's with actually addressing the culture and the systems and policies that we have in place at our place of work. And we actually develop an environment that is culturally a safe place where everyone understands that if you are working here, we are really putting emphasis on developing a relationship where everyone feels that they are important and everyone matters. And then also on the individual level, we each practice cultural humility, which is a practice of understanding that the patient is the expert and the provider is then the learner. And we're actually learning from the patient the best way to take care of this patient. And we're going to talk a little more. If you join us in our learning collaboratives, we're going to have a learning collaborative in the spring of this year. If you join us at the learning collaborative, you will hear more about creating a culturally safe place as well as cultural humility. Next slide, please. So there's actually a cycle, we can get into actually what they call a self-fulfilling cycle as healthcare providers, where we think that a patient is going to act a certain way. So, we have these perceptions and expectations and an idea about a patient, and then that it influences the way that we actually interact with the patient, and that feeds into how the patient acts or how they respond to how we are giving different information or how we're acting to them. And then which actually leads to the expectation fulfilling, so if we think that a patient's not going to do it, we give them very little information, we act a certain way, we don't have any eye contact with them, the patient kind of feeds off of this. And so they actually fulfill what we have projected on them. But cultural humility, next slide, actually helps block that first perceived idea. And so it interrupts that cycle where we would actually fulfill some of those expectations that we have on that patient or client. And again, we will talk more about cultural humility during our learning collaborative and dig down more into that concept of that. So next slide, please. So in summary, just want to make sure that we understand that implicit bias is pervasive. People are often aware of implicit bias. People differ in the levels of implicit bias. implicit bias can really impact how we deliver services as well as information. And so that is the connection where we know implicit bias can hinder patient-centered care. And one way that we can mediate implicit bias is to become more culturally humble, as well as create a culturally safe environment. And I believe that's my last slide, so I will pass it on. And here's some resources that tell you more about implicit bias and ways that you can actually mediate the implicit bias. So I'll turn it up over to our next speaker, and I believe that's Alexis. Thank you.
Thank you, Darlene, and thank you for that great overview of implicit bias. And I look forward to diving into it more during our learning collaborative. As we think about transitioning to patient-based care, as Darlene described, we also need to think about not only our implicit biases, but also about the factors that impact our patients' population's health. So to that end, we have an activity to just kick off this discussion. So if you go to Mentimeter again and you put in the code at the top, I would like you to share what you think the population you serve, what are their barriers to care as you think about, who you serve, whether that's farm workers, people experiencing homelessness, those in public housing, and others that your health center serves. So I see transportation, access to resources, poverty, absolutely, language, lack of insurance and expenses. Cost is certainly a huge barrier to care. I'm just looking at transportation, income. There's a lot coming in. There are so many barriers to care, as we see. Time is certainly an issue, especially for those who may not have sick leave. Low wage earners don't tend to have sick leave available to them. So time and lack of wages is certainly a huge barrier. Thank you, everyone, for contributing to this. And someone mentioned social determinants. So actually, that's a great way to transition to our next slide. So these different factors that we think about, the transportation, the poverty, the lack of health insurance, the food insecurity, all of these different barriers that all of you mentioned in the previous slide, these are also known as social determinants of health. And essentially, social determinants of health are conditions in the places where people live, learn, work, and play that affect their health. And it's important to understand that these factors that are largely outside of the control of the patient impacts their health and their access to healthcare. And I know that we talk about social determinants a lot, and I imagine that many of you are familiar with the concept, but we did just want to provide a brief overview just so we can talk a little bit more as we talk more about that patient-centered care and that relationship-based care and creating resources that really put the patient at the center. So next slide, please. So as we think about the social determinants, and specifically as we think of them as they relate to diabetes, what are some of those determinants that we need to think about? And again, many of you mentioned these in the word cloud that we had a couple of slides ago. So of course, socioeconomic status, as well as access to food and transportation, and language. Language is a huge barrier, but we also have to think about race and ethnicity. As Darlene talked about implicit bias, thinking about someone's race and ethnicity and how that interacts with the health system and their overall living and working conditions and their socioeconomic status, it's important that that is also kept in mind, as well as a history and experience or trauma. And that can be societal trauma, it can be personal trauma, but that also impacts a person's ability to access healthcare and specifically to manage their diabetes. It may prevent them from from having insulin. It may prevent them from going to the doctor if they are experiencing any effects from diabetes. They may be scared of going to the doctor. So we have to think about all of these different issues as we create these patient-centered resources and create a management plan with our patients that really put the patient at the center. Next slide, please. So in order just to illustrate this point a little bit more, I want to just do a quick case study. So this case study focuses on Roberto. He is a farm worker and he was recently diagnosed with type 2 diabetes. He lives alone in housing provided by his employer. He is only in the area for a few months, and he will then return to his home country of Mexico. He understands Spanish, but he's actually more comfortable in Mixteco, which is an indigenous language spoken in Mexico. He is not able to read Spanish well, and he only has limited English proficiency. So I want to ask all of you, looking at this case study, what are some of the factors to consider when you're providing diabetes support to Roberto? And you can go to Mentimeter again, and you can provide your responses to this question, your reactions to the case study. You also are welcome to include them in the chat as well. So language, absolutely, especially because not only is he limited English proficient, but he also is limited Spanish proficient. So ensuring that there is that access to Mixteco interpretation, but also understanding that as an indigenous worker, he may have a different cultural lens than another person from Mexico. I also see health literacy, absolutely. Using pictures, yes. So making sure that it's very graphic so that he's able to visualize in multiple ways how to provide, how to manage his diabetes. Immigration status and insurance. I did not share his immigration status, but I was thinking that he was an H-2A worker. So he was a worker who was here on a temporary non-immigrant visa. So he is legal in the US, but only for a short time. And his visa is tied to an employer. So certainly something to think about. Continuity of care, absolutely, because he's going back to Mexico. Other issues that may be of concern, including financial issues, sanitation, absolutely, the condition of his housing. He may not have a refrigerator, so if you provide him insulin, he may not have the means to actually refrigerate the insulin. So thinking about his housing conditions, we're thinking about the plan that you come up with the patient in order to help him manage his diabetes. Educational level, these are such great answers. Thank you for responding. Healthy food as well, absolutely, because farm workers generally, in the cruelest of ironies, are extremely food insecure. So they don't necessarily have access to the healthy food that they themselves harvest. So thinking about that lack of access to food. So all this is to say, and thank you so much for all of your responses, that it's important when we create these plans, when we create these resources, that we look at the whole person, that we not only look at, the health condition of that patient, that patient has diabetes, but that we look at all the different factors and circumstances of this patient to really be able to fully understand, what is contributing to this patient's health, and what are the challenges this patient is facing and may face that will impact their ability to manage their diabetes. So with that, I am going to turn it over to my colleague Jillian to talk about patient-centered care. And thank you for your participation. It was fantastic. Thank you.
Thanks, Alexis, and welcome to everyone. We're happy to have you all with us. Just to continue on with the concept of patient-centered care, just want to point out some of the real evidence-based benefits that one finds in settings that are patient-centered. We do understand there's been throughout history of care delivery, this shift in the power balance And we're seeing more and more in recent decades, the shifting of locus of control toward the patient. And that really requires the system is orienting towards the patient, that the education is orienting towards the patient. And as we've learned so far, every patient is different. So we just want to highlight here a little bit of the benefits we have. There's this improved quality of care delivered from the healthcare professionals, that increased patient satisfaction and provider satisfaction. The benefits to the patient are improved experience of care. They have a higher adherence to treatment recommendations, and that building of a trusting and lasting relationship between healthcare professionals and the patient. And again, we are helping patients be more knowledgeable and better prepared to discuss the medical concerns that they're addressing, and really have a better understanding of what recommendations are being given. So we can go to the next slide. The Institute of Medicine's Crossing the Quality Chasm, a New Health System for the 21st Century, defined patient-centered care as providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. Researchers from the Harvard Medical School went on to develop, with the Pitker Institute and Commonwealth Fund, 7 primary dimensions of patient-centered care, and then later expanded these to include an 8th, which is access to care. And these are respect for patients' values, preferences, and expressed needs, the coordination and integration of care, information and education, physical comfort, emotional support and alleviation of fear and anxiety, the involvement of family and friends, continuity and transition, and access to care. The next slide. So, this is a lot to kind of process as a care team or a health center. And so really helping your teams develop an overarching philosophy around patient-centered team-based care can help everyone have the same mission and the same objectives, and really help support buy-in to this concept. So some of the components that might be discussed for really creating a philosophy for the care teams could be that, the provider team is really viewing the patient as a whole person with rich lives of varied personal and cultural needs and preferences, and the ability to make important contributions to their own care. That provider teams will be seeking not only to earn patients' trust, but also trust them to make the most appropriate healthcare decisions for themselves, given their personal needs, preferences, and circumstances. And next slide. So that being said, there are serious practical barriers for really implementing patient-centered care. I think that we've all have had experience with these fundamental power differentials between providers and patients in clinical care settings. There might be this paternalistic tendency among clinicians. There's also fear from patients that they may be perceived or labeled as difficult or receive less adequate care if they're participating too actively or if they're too assertive in the decision-making process. Of course, one barrier that's often talked about is this time that's not available to really engage patients and families. We understand how fast that patient encounter can be, and we really understand that being more patient-centered requires more time. There's often an uneven training of clinicians in the necessary communication skills. There's also insufficient access to decisional aids. There might be conflicting agendas in the clinical encounter. And so for many reasons, the promise of patient-centered care may remain elusive for many folks. So, we really want to help look at some of the strategies. Definitely creating champions within the care setting, helping individuals understand that their patients understand that they're really being asked to be more engaged in their care decision-making, that there can be more training for staff and caregivers to be more involved with the decision-making process and really involving patients in that process. Next slide. And then, some of the real, I think we have to go back one. Some of the real resources, missing one. So going on to the ethical conflicts, there's a, real concern, like I said, with the amount of time necessary. And in primary care, we really don't allow a lot of time for decision-making. So we have to start relying on patients to be the primary manager of their care and be engaged with the care plan and feel capable to implement that care plan on their own in their own lives. Or, another ethical kind of thing that could arise is that patients choose not to implement the care plan as designed or do not seek treatment at that time. Next slide. So, trying to create some resources to support patient-centered care. These are some examples of current strategies. That includes shared decision-making, provider training, such as patient-centered techniques like motivational interviewing, even developing shared medical appointments so that we build that community and have more time with a group. And then, of course, supporting the multidisciplinary and interdisciplinary case management approach. And next slide. So AHRQ is defining shared decision-making as occurring when healthcare providers and patients work together to make a healthcare decision that is best for the patient. And the optimal decision takes into account evidence-based information about available options, the provider's knowledge and experience, and of course, the patient's values and preferences. Next slide. So some tips for shared decision-making, which is really at the heart of patient-centered care in practice. You really want to invite the patient to participate. Let them know that they have options and that their goals and concerns are a key part of the decision-making process. Present the options. Patients need to know the options that are available to them. They need to know the risks and the benefits. So based on all the best available scientific evidence, really lay out the risks and the benefits, go back and inquire if the patients are understanding what those benefits and risks are. Then assist the patients in evaluating the options based on their goals and concerns. So weighing those in kind of crosswalking them with the benefits and risks, their goals and concerns, so that they're really able to direct their attention on what is important to them and what they are concerned about. And then facilitate that deliberation and decision-making process, giving time to think things over, supporting them to look at more closely what else they need to know before they make the decision, before they're comfortable making the decision. And then very much supporting them in the follow through with the decision making. So helping them define next steps, checking for understanding, asking about what challenges might be presented when they're carrying out this decision. And next slide. These might be some great example questions. So these are really rooted in fundamentals of motivational interviewing, having open-ended questions, and also very much aligned with remembering that we're trying to highlight patients' goals and values here. So what would you like to be able to do? What can you do to make this happen? How is this affecting your life? How would you like to proceed from here? So these could be great questions to have your nurses guiding, conversations with patients, for example, other staff, also the providers, of course. But when time is of the issue, you might have to rely on the care team beyond the provider. And then we just want to bring a little bit of attention to these decisional aids on the next slide. They are tools that help people become more involved in the decision-making process by making explicit the decisions that need to be made and providing information about the options and outcomes and clarifying personal values. So you can go to the next slide. Yeah, so these are decisional aids. And on the next slide, I have an example of one that was developed with AHRQ. It's called the SHARE approach. The SHARE approach is on the next, I think it's the next slide. So this is, S is, seek your patient's participation in the decision, help your patients there it is. Help your patients explore and compare treatment options, assess your patient's values and preferences, reach a decision with your patients, and evaluate your patient's decision. So the AHRQ SHARE approach is designed to guide shared decision-making by analyzing healthcare options, advantages and disadvantages, and potential risks. The options are identified by meaningful dialogue and allows the patient to openly express what is most important to them. And according to the AHRQ, the benefits of the SHARE approach include increased patient satisfaction, resulting from improved care quality and good care experience. And the model helps to build trust between healthcare professionals and patients. This is one that's really recommended. As we go to the next slide, we just want to invite everyone to participate in a quick poll regarding what strategies or patient-centered techniques are you implementing in your care settings? So this will be another Mentimeter engagement activity. So in your health center or care setting, which of the following are used to engage patients in their care? And you can check multiple options here: community partnerships, goal setting, shared care plans, materials at a third grade reading level. So, acknowledging the medical literacy needs there, shared medical appointments, motivational interviewing, patient advisory councils, for example. This is great. So a lot of use of great strategies to really build those trusting relationships and stay patient-centered in our care delivery. That's great. We can just leave this open for a little bit longer and then close it out. Thank you, everybody. So then these are just some resources, some other varieties of decisional aids, some resources that are helping implement step-by-step implementation for patient-centered care. So hopefully these will be helpful. I think that wraps up my section, I think. And I'll pass this back over to Emily, I believe.
Well,
Or
thank you.
Cindy, okay.
Thank you very much. We had one question in the chat that I would like to ask. And then I invite all our participants to either ask your question in the Q&A and we could put it out for a minute or two to our panelists. But Jillian, this question is, what is a shared medical appointment? And is it something that can be used in FQHC setting?
The shared, I think some folks answered that they're doing that, so they might be able to share where they are for peer learning sharing. But the shared medical appointment is when it's sometimes modeled like for certain populations. So you might have multiple people attending one medical encounter where they're having similar medical concerns that are addressed together. So they would do kind of a quick check-in with each person and then use the bulk of the time remaining to do a larger education opportunity or build that peer support in the setting. So centering is one that is very sort of trademarked and done in various settings for women that are experiencing pregnancy. There's others that are done for diabetes management. And it's, even with hepatitis C treatment, sometimes they're done in cohorts, where cohorts will be on a rolling basis. And then those folks are working together a little bit for education purposes. So that is one way to build community, to have that support across the population, and also people enjoy kind of being with others when they're sharing a situation like a medical concern.
Thank you. Thank you very much for sharing that. I do want to take a minute to thank everybody for their presentations today, and to ask our participants to please take just a few minutes to fill out our evaluation. The link is in the chat. Thank you very much, Albert. And we have our QR code here. And if you are seeking continuing education units, please fill out this evaluation. And once we have approval, you will receive your certificate via email. And should you have any questions about that, please reach out to Migrant Clinicians Network. Thank you very much, everyone, for attending today. We really appreciate it. I want to also remind you, we have 2 more awesome sessions coming up as part of our fall learning series. Next week, join us for a webinar exploring the shared experience of health centers, examining barriers to diabetes care and solutions to advance health equity from lessons learned during the last year. Our very engaging panelists will provide insight to their challenges and successes, as well as provide strategies for maintaining quality patient care amidst a public health emergency. And lastly, our debut Spanish webinar on Wednesday, November 10th, addressing diabetes management during a disaster. Next slide. Again, next week we have our webinar number 3, and those will be our NTAP faculty, as you could see on the slide. The National Center for Equitable Care for Elders, Fenway, and the Corporation for Supportive Housing. Next slide. Might be it. Oh, thank you. Thank you today to our wonderful panelists, Emily Kane. Thank you for running the slide deck. Jillian Bird, Darlene Jenkins, and Alexis Guild, and Albert Eisen Jr., as well as Health Outreach Partners intern Vanessa Reed for all of her help during this presentation. Again, please take a minute to do the evaluation and have a fabulous day.